So, as the title says, we are going to talk about serving the underserved in our trial populations, but particularly on lessons learned. So as we go through, we'll tell you a little bit about what we have learned, and hopefully you'll take something away from that. And you'll also see that we've learned slightly different things. Okay, so immediately, there we are, brilliant, great. So what you'll see is it's a team effort. So Simone said there are 4 of us, and we'll switch from person to person depending on what we're talking about. Again, as Simone said, we're going to share the slides, so our email addresses are all there should you hear something that one of us says and you'd like to get in touch to learn more outside this presentation. What we'll cover today are the 3 frameworks that we've been working on. So we'll give you a little outline of the frameworks and the work we're doing, a little bit less on the ethnicity framework, because I'm guessing that at least some of you will have heard about that before. So we'll give an outline, but a bit less, a little bit more on these 2 other frameworks. You may not have heard so much about them. And then we will, as I've just said, say something about what we personally have learned from the process of working with these frameworks. And we anticipate having plenty of time discussions. I'm hoping that we'll have 20 minutes at least, maybe 25 for discussion at the end. So if you do have questions that come to you, please do ask those questions. So the Include Ethnicity framework, this is work that started, well, I suppose in one form or other in 2017. So it's been kicking around for a while, but in earnest really in 2019. And as the name suggests, the idea behind the framework is to highlight to trial teams at the trial design phase issues about their disease area, the disease area they're focusing on, the intervention, and their trial design. Issues around all of those things that may affect the ability of different ethnic groups to take part in their trial. And the reason for doing that is that we think, as do others, that if these issues are not considered, it is likely that that trial will not involve the people it needs to involve for its results to apply to all of the individuals who could benefit from that intervention if it proves to be effective. Okay, so it's not, we're not coming at this, any of these frameworks really from an ideological, this is what we ought to do, although we should, so that is a reason for doing it, but it's bad science not to do this either. The work that we do will be poorer even if we restrict ourselves to scientific quality. There are a range of other things where it will also be poorer in terms of equality of opportunity, etc., etc. But this framework is about improving our trials and the results they provide, as it is for the other frameworks. I wanted to show this slide, which you may not have seen before, and this is a diagram that one of our collaborators suggested we produce to show the process of developing the ethnicity framework. And what I really want to get across with this picture is that at the left, it starts with a few of us sitting in rooms together, kicking ideas about. And by the middle, we're really getting stuck into talking to lots of people to tell us, well, what do you think we should do? What do you think of this? Could this be improved? And then there's a big chunk in the middle, phase 5, that has all these colored blocks where we are really talking to lots of people. And then there's this plethora of arrows going backwards and forwards where we try something, put it in front of people, they say, well, it's not bad, but change this, and then we go round. And I guess that process is absolutely essential to have some belief in what comes out at the end. So I don't think without all of those colored blocks and the groups we talk to and the arrows going round, we personally, certainly myself, would have much confidence in the tool itself. But because of what's in front of us right now, I do. So I am confident that the things in that tool are things that will help improve trialists' awareness of challenges that their trial will pose to the widespread ability of different ethnic groups to take part in their trial. So consultation like this is a feature of all of these frameworks because there is no other way of getting insights into what is important. And that is definitely the case for this particular framework. So overall, there are about 40 individuals involved in this framework, and a relatively small core team, but a much bigger consultation group. So to cut to the chase, what is the Include Ethnicity Framework? It's a two-part tool, has some key questions and then some worksheets that help you complete the questions. The key questions are linked to the worksheets in that the key questions pose ideas that are really meant to get you thinking. So for example, it's going to sound trivial, but who should be in the trial is actually far from trivial. And I would say that we have tended to date to concentrate on clinical eligibility criteria and not really thought about it, and who are the people who have those clinical eligibility criteria. So we need to think more about who should be in our trial and think more broadly than clinical eligibility. Start to think more about socio-demographic characteristics, for example, or for example, in what I'm talking about, the ethnicity of the individuals who could benefit from this intervention if it was effective. And then it asks other questions. Are there things about the disease area that will make it easier or harder for some people to take part? Similarly, the interventions, things about it that will make it easier or more difficult to take part. And then the trial design. And the trial design one in particular is something which we have a great deal of control over. So now a gift to make changes. Might come on to something about evaluation. I have something to say about that perhaps later. But these are the 4 questions meant to get you thinking. I think they're really quite difficult to complete without the worksheets. And that's why we started developing these worksheets. So that makes it easier, we hope, for trial teams to think through, well, how do I figure out if the intervention I'm proposing is going to make it more difficult for people to take part? That's what the worksheets are at. So they ask a series of questions that I am confident are important because of that consultation exercise. And these questions are important in teasing out what about your intervention, for example, might make it tricky for people to take part. And this is the last of my slides before I hand over to Heidi. We have a bunch of resources on our website, including trials where we have applied our framework, which would give you an indication of the sorts of answers to these questions that you might find. Once you start asking these questions, I can guarantee you start to find things that your trial is throwing up as potential challenges. We also have other things such as a video that gives perspectives from people of different ethnic groups as to why this sort of work is important to them, why therefore it is essential that we take account of this. Okay, we can obviously talk more about the ethnicity framework in the questions, but right now I'm going to hand over to Heidi, and I'll move to the next slide, shall I, Heidi?
Yeah, please. Thanks, Sean. So I'm just going to give you a very quick sort of bridge between the ethnicity framework and the socio-economic disadvantage framework, which Fran will talk a bit about. But I worked on both, so the learnings from that definitely fed into particularly the socio-economic disadvantage framework. So the learnings about this were the literature around ethnicity and health is not the most straightforward thing in the world, and there are people where this is purely their area of expertise. But the thing that came out to me multiple times throughout the process of making the ethnicity framework was that often we're saying that risk is a risk factor, that race is a risk factor. And that is often coming from people with a huge amount of privilege. Often it's white people that are saying that. And when we look back at things that is actually tying into, it's not that race is a risk factor, it's that racism is. And often in the literature around the ethnicity work, socioeconomic disadvantage is being used as a proxy for ethnicity, which is obviously, there's a million problems within that. But the issue there is that we needed then to untangle that. So we knew that when we were doing the ethnicity framework, this was not going to be the only disadvantaged group that needed to be helped essentially by trial teams. We knew that this wasn't going to be the only focus. So in conversations, and I'm sure that it was in a TMRP meeting that we had, the inclusivity subgroup, socioeconomic disadvantage came out as sort of the natural second thing for us to do. And I sort of went into it, I'm not sure what Fran will think, but I sort of went into it thinking like, how hard can it be? We've done the ethnicity one, we've got this model, we'll go into socioeconomic disadvantage and it'll be the same sort of thing. And I've worked on both and that'll be fine. How wrong was I? So first off, just to highlight some differences. So ethnicity is a protected characteristic, socio-economic disadvantage is not. And that was a big thing, but also socio-economic disadvantage, as you'll hear from Fran, is transient, and that sort of experience that people have changes and can change overnight. So for us trying to create this magical framework that will help trialists to try and, encourage people to engage with their trials properly, that was hard. So I just wanted to kind of litter some learnings along, before we go into the next framework. But yeah, I'll pass on to Fran now and she'll talk about the socioeconomic framework in more detail.
Thanks, Heidi. So yeah, I've just got a few slides talking about the socioeconomic disadvantage framework. So it's co-led with myself, Katie Biggs, who I think is also on the call, and Heidi Gardner as well. And we've assembled a patient and public contributor group as part of this project as well, focused on individuals who describe themselves from a background of socioeconomic disadvantage, which I'll go into in a little bit. And we obtained some funding from the University of Liverpool to fund that public consultation work as well. Next slide, please, Sean. So very similar to the ethnicity framework, the socioeconomic disadvantage framework is intended to guide the deliberations of funders, researchers, and delivery teams as they design and assess clinical research proposals. And ultimately, the idea is to engage with and improve inclusion of individuals from socioeconomically disadvantaged backgrounds in clinical research, because we know that they are widely underrepresented in clinical research, which is obviously especially problematic since, for example, with cancer-related studies, where we know that those from the most disadvantaged groups are often those most affected in terms of outcomes and mortality. Next slide, please, Sean. I think there might be some other bits on this slide. Oh, there we go. Yeah, so very similar to the framework development process that Sean showed us earlier. We tried to adopt, as Heidi was saying, we tried to adopt and lend bits from the ethnicity framework, so it wasn't like starting from scratch. So in terms of the development process, we were able to be guided by that as a process. But as Heidi said, it wasn't quite as we may have expected it to go. So what I can talk to you today is where we're up to, what we've done so far, where we're up to, and what we intend to do next in terms of the process. So as mentioned, we assembled a public contributor group, and we use two tools to do this. We use People in Research, which for those of you who might not know is a website where you can put an advert out there and just say that you're looking for public contributors, from such and such a background, or who might be interested in such and such a condition, and then they sort of apply to be involved in the project. And also via NIHR ARC, and they also have a patient and public involvement network as well. So again, we sent an advert around that. And we asked within that advert, we were looking specifically for people who identified themselves to be from socioeconomically disadvantaged backgrounds. So for example, they might be from a low income background, or they might be in receipt of government benefits. And we received a number of responses, and we have a group of 6 contributors who have been fantastic on the project. So we had an initial meeting back in around March last year, April last year, where we talked about developing an outline of exactly what was needed of this framework. So we looked at the definition of socioeconomic disadvantage, which in itself is very complex, so that, starting off as well. That was tricky trying to kind of iron that out, and it's still something that we're looking at the moment, in fact. And also we talked about the barriers as well, in terms of what are the barriers that individuals from socioeconomically disadvantaged backgrounds face in engaging in research and, being retained in a trial, if you like, as well. So, and also sort of identifying as part of that process as well, when we had that meeting, there were suggestions made of what things can help, what researchers can put in place, sorry. Can we do the next slide, please, Sean? So this is just a bit of sort of brainstorm, if you like, in terms of what came out of that initial meeting around barriers to engagement. So I think the thing that surprised me, and hopefully I don't sound like an arrogant researcher, but I think sometimes we do have assumptions as researchers of what we think might be the issues, what might be the barriers already. So some of those things I'd already considered, like the association between education levels and literacy and socioeconomic status. For example, payment issues. I'd heard people talk about before, you know, whether people should be paid in cash or whether people should receive vouchers, so that doesn't affect benefit payments, for example. So there are a few issues I was already aware of, but there were other things that came up that I hadn't really given so much thought to, which still to me seem very much important. And for example, public contributors talked about trust and connection. So for example, going into a consultation with a health professional, who quite often we know that clinicians are from the most advantaged backgrounds. And for example, if you're coming from the most disadvantaged background, there can be difficulties there in trying to kind of build up that trust and that connection in that relationship, and building up rapport can be challenging. And confidence was another thing that came across as well. So some of the public contributors just talked about how there's like many people coming from disadvantaged backgrounds just don't have the confidence maybe to come forward and to ask questions and to engage in those consultations, for example. So there were things like that that I hadn't perhaps given so much thought to really, but this sort of shows a map, if you like, of a lot of the issues that came up and how complex it is as well for us as researchers to try and address all of those things. So Sean, could you go on to the next slide, please? Thank you. And try not to sound too much like Chris Whitty here. So yeah, this is sort of where we're up to. So we had that developed an outline of what was needed and developed an initial draft of the framework. So we went away from those meetings with the public contributors and we were able to draft an initial framework. So Katie and Heidi and I drafted that initial framework, and then we went back to the patient and public involvement group and we collated all of their comments on that. We made another, it's an iterative process, I guess, and it's making another version of the framework then. And then very recently, back in November, December time, we had another meeting where we brought together the wider stakeholder groups. So we brought together individuals like health professionals, methodologists, and again, many of whom might be on the call today as well. Individuals from funding backgrounds, ethics backgrounds, patient and public representatives, and many more as well, just to try anyone who's involved in that sort of research decision-making process. And we again was a really, really helpful meeting, very, very useful, about 2 hours discussing how we can improve the framework. And at the moment, we're in the process where we're modifying the draft based on the feedback from stakeholders. So the next steps for us, once we've finalised modifying this draft, is we're going to send that draft back out to the stakeholders and then receive some feedback, hopefully, and we'll be able to finalise that draft. And I guess the final point there, point 7, about combining the frameworks for underserved groups, is something that we'll talk about later in terms of the next steps, because it's not just an issue here for the socio-economic disadvantage framework, it's something more broadly, because I guess if we have too many of these frameworks, it will become difficult for researchers compiling grant applications to manage. So they're the sort of next steps. I'll hand over to Vicky now. Thank you.
Thanks very much, Fran. So I'm going to talk a little bit about the impaired capacity to consent framework, and that's on behalf of the team that you can see listed on the slide there. Thanks, Sean. So why develop and include framework for these kind of populations? Well, in part because capacity in itself is a very complex construct. So you've already heard how socioeconomic disadvantage is more complex than we might think, and ethnicity as well, and capacity similarly. So important to bear in mind that there's a legal presumption of capacity. So you assume someone has capacity unless demonstrated otherwise, but importantly, it's decision and time specific. So someone might have capacity to make some decisions, but not others, or not at other times. And while we might think about it particularly being associated with long-term conditions, so dementia would probably be a well-known example. Of course, it can accompany an acute event, so a cardiac arrest, a stroke, or be associated with a lifelong disability, perhaps a learning disability, or there could be a combination. So when we think of an acute event happening up to someone who is already experiencing a condition that impairs their ability to make decisions, you can see how additionally complex it might be. And the prevalence, of course, varies considerably between the different populations and different settings. So, for example, perhaps 30% of people in a medical acute setting might lack capacity to consent, perhaps 70% in care home, up to about 90% in critical care patients. So you have that kind of variation between populations and settings. And that means, and other factors mean, that trials involving this population are very complex. So unlike some of the characteristics of underserved groups we might think about, which perhaps are relatively static, capacity is a very dynamic and fluctuating construct. Someone might lack capacity at the outset to give consent to take part in a trial, but they may gain capacity during a trial, capacity may be lost during a trial. And importantly, and unlike other groups, there are particular ethical considerations, because the way the legal frameworks and ethical frameworks are set up, as researchers, we have to justify why we're including people who lack capacity in research, why we couldn't just do our research with populations who are able to give their own consent. And so we don't justify why they're excluded, we have to give justification for including them. And the legal frameworks themselves are quite complex, depending on where in the UK, and of course other jurisdictions as well, on whether it's a CTIMP or not. Thanks, Sean. So thinking about adults lacking capacity as an underserved group, so we know that exclusion of people with cognitive impairment is widespread, and that's even in areas that we talked about and populations we talked about where there are high levels of cognitive impairment. And hip fracture is quite a good example of this. So dementia, for example, is a risk factor in falling and fracturing your hip. We know that more than 40% of people with hip fractures also have cognitive impairment. And we know that this population has much worse outcomes. So, for example, they have 67% higher all-cause mortality in 30 days after a hip fracture. But 80% of hip fracture management trials, so those looking at the kind of surgical management, exclude or just kind of ignore people with cognitive impairment. And 83% of rehabilitation trials looking at people following a hip fracture exclude people with cognitive impairment. And that's even though the small number of trials that do include them show that they can experience quite improved outcomes around mobility, pain, and also cognition. And what that means is that the NICE guidelines for hip fractures themselves state that many of the recommendations they make cannot be said to apply to this population because they're excluded from these trials. And we've also seen that during COVID-19, where some of the groups who've experienced the most devastating impact from COVID-19, and you can see some examples on the slide there, are those least likely to have been included in COVID trials. Next slide, Sean, please. So when we think about what some of the barriers to including adults lacking capacity is, this is some work that I've previously done where you can think about them as kind of incorporating systemic factors. So I've already talked about the complexity of the legal frameworks, of navigating the ethical review process. And if you've ever been involved in that, you'll know what I mean. But also the kind of infrastructure that's really not set up necessarily to include people who lack capacity, and the additional resources that are required, time, skills, those kind of things. But also then the kind of methodological issues as well. So the kind of eligibility criteria where people perhaps automatically put down must be able to give consent. But then there are also issues around a lack of appropriately designed interventions for these populations, and also validated outcome measures. Thanks, Sean. So in terms of the development process for this particular framework, so we started about a year ago, and the intention, as we've already heard with the other frameworks, is to help researchers to kind of overcome some of these barriers, and so design trials that are more inclusive of these populations. So say we formed a group about a year ago, and you can see the names of the core group on the bottom of the slide again. And then that's when we really talked about thinking about the scope and content of the framework. Again, adapted the ethnicity framework to kind of avoid that kind of reinventing the wheel, and drafted the first version. And then importantly, we needed to do some kind of proof of concept work. So it does the same kind of approach of having these questions about who you should be including and why they might be excluded apply to these populations. And does it apply to all of these populations? So could one framework work for people that, for example, have a neurodegenerative condition like dementia, as well as someone who has had a cardiac arrest, for example? So as part of the consultation period, we then went out to some of the specialty leads in the kind of relevant NIHR and Healthcare Research Wales groups. And they kind of gave us feedback around what they thought applicability might be to the kind of populations they work with. And then we piloted it in a number of trials and populations. And many thanks to the specialty leads and also to researchers that piloted it for us and gave us quite a comprehensive feedback, which we've used to revise the framework. And our next stage with Warren at the moment is that kind of third consultation stage. And from a public involvement perspective, it was important that we ensure that the groups we hope will benefit from the framework are involved in its development. But we needed to do that kind of proof of concept work first before including people from those groups that perhaps the framework might not have been applicable to. So that's why we've kind of done it in that order, if you like. And also important that the public involvement activities themselves are accessible to these kind of populations who have cognitive impairment, will have very different communication and support needs. And then obviously we'll be doing further work to finalise the framework and take it on from there. And in terms of the content of the framework, Sean, if you could move it on, please. So just briefly, the structure and content. So we've kept very closely to the ethnicity questions because it might help thinking about them as a kind of, I guess, filter questions when we might think about bringing them together later on. We've tweaked some of the wording, you can see in italics, away from the wording of treatment in question 2, because it might not be a treatment trial. And in question 4 about remaining in the trial, not just taking part. And of course, retention important in all trials, but particularly with these populations where if someone loses capacity during a trial, quite often the researchers will withdraw them from the trial. We've changed the ordering a little bit as well, so the worksheets follow directly on from each question rather than all the worksheets being at the end, because the feedback was that actually flipping back and forth was a little bit challenging for researchers. We've also put some additional information in about the legal frameworks because understanding what the provisions are for this population was very important. So we have that in an appendix. And we have lots of links to guidance and tools to help researchers. An example you can see on the slide there is a website I've developed that kind of collates a lot of the information and resources and tools that researchers might find useful around capacity and consent. So I will hand back to Sean, I think, to talk about what we've learned.
Thanks, Vicky. So what we'll do, each of us now will give one slide on some of the things that we have learned from our experience of working on one or more of these frameworks. So here are some key things I've learned. So one of them is that trials have historically been developed from the perspective of the designers, people who are very often people who look like me, sort of middle-class white men, middle-aged. And that, I'd say, again, it might sound trivial, but is actually a big revelation. It means that we design trials to suit people like us. And the second point, Fran said something which fits in very nicely with this as well. It is very hard, to impossible, to put yourselves in the shoes of people who are not like you. So I think what you said, Fran, was that there were some things you did sort of predict would be important, and then things which were definitely not expected. That is what it's like. We can't guess, which is why developing from our own perspective is not the approach that we are now suggesting, because we cannot put ourselves in the shoes of others. So that's what I've learned. Like, we just have to talk to people. If we don't, we will mess up. Third point, we need to think much more carefully about who needs to be in the trial. So not only think about, we've got a sample size of 400, how many people do we have in the trial? We need to think about, and who are the people we have in our trial, and how do they reflect the population of people who have the condition and could gain benefit. I think there's a recognition that all of us, and particularly funders and perhaps reviewers of funding applications, need to think about, which is this point 4, which is, I think for a while, if we take these things seriously, trials are going to become slower and they're going to become more expensive. And I don't think that is some new inefficiency that we have thrown into trials. It's that we were not doing things properly before. So this is just an acknowledgement that by not doing things properly before, trials managed to get done in the speed they did, and they also were that bit cheaper. I do not think that is going to be the way forward for a while at least. And the while at least is because we will get, I hope, better at this because of evaluation, which is my last point. And that over time, we won't have to work quite so hard because we'll have established relationships that we currently do not have with groups that need to be in our trials to a greater extent. Okay, so they're the key things that I've mentioned. The last one there again, evaluation. And I now pass on to Heidi.
Thanks, Sean. So a few points that I think kind of tie in with yours, but I just wanted to really hammer the point home. Researchers are not a particularly diverse group of people at all. And when you start to look at the people that are in the room to make decisions around research, you slowly start to realize that you're probably all thinking similar things because you've all probably had similar experiences in life. And to change that, we need to change research culture. And that's obviously a much bigger task than any of our careers will allow, but it is something that we all need to try and contribute to. So things like, why do most of us look white? Why are most of us able-bodied? Why are most of us middle class? That kind of thing. We need to try and be conscious in our hiring practices, be conscious in the way that we create research environments, even down to the way that our buildings in research look. Tying into that as well as another mirror of the privilege that we all have, but there is much more work to do in this area than I ever thought before starting working in this area. So I started working in this area and thought this will be great, a couple of projects and we'll have solved it. Shocking, absolutely shocking. We will not be solving this in 2 projects. And tying into that again, there are groups of researchers, and I probably should have just said people here, they're not just all researchers, but working outside of trials that we should be routinely collaborating with to strengthen our trials. So medical historians, anthropologists, linguists, people that we maybe haven't thought of as being core people in the room when we're making trial design decisions should be in that room, because those people understand society better than us trialists do. And again, seemingly small, simple changes have the potential to make a big difference to how people feel. And that is essentially what we're going for. We're trying to make people feel better about the trials that we're doing. We're trying to make them feel included and welcomed. And that those small, simple changes go both ways. They can be positive and they can be negative. And I think one of the main things that I've learned throughout this whole process is that many of the small things that we're doing are negative, and therefore it's easy, or it should be easy, to undo them and to therefore create a more positive environment for people. Saying that, it's not a simplistic change. We do need big changes as well, but we need to reframe how we think about them. So as Sean said, these are not extras. These are not inefficiencies that we're just, throwing in. These are proof, essentially. These activities are proof that we haven't been doing it correctly before. So to me, they don't cost more money. They just cost the money they should have costed earlier. And we've been discounting ourselves for decades previously. So yeah, that's my 5 big epiphanies, and I'll pass on to Fran now.
Thanks, Heidi. So yeah, I think obviously the focus of this work is around making research more inclusive. But one of the key points that for me came out of it as well is around patient and public involvement. And actually that needs to be diverse, it needs to be inclusive. And I think that is a massive issue at the moment. And if we want to do good research, it needs to be built on foundations of good patient and public involvement as well. And like Sean was saying earlier, we need to speak to people. And if we're going to be speaking to people about projects that we want to be inclusive, for example, around socioeconomic disadvantage, then the PPI needs to be representative too. And one thing we have found with the work that we've done over the public consultation work is, for example, we asked to involve people who describe themselves as, being from sort of a low income background or maybe in receipt of government benefits. But often we would speak to people and they would explain how they may have been in a more advantaged position previously, and some sort of life event or health condition or something had occurred which resulted in them being then in the more disadvantaged, from a more disadvantaged background. But I'm not hearing from people who talk about how they've been in a disadvantaged background throughout life. And I think that's really important, that those people need to be involved. So I think that's something we all need to look really carefully at. How can we do that better? obviously, as again, like Sean touched on earlier, about socioeconomic and Heidi mentioned about socioeconomic disadvantage being incredibly complex and fluid, as Heidi said, really, I guess ethnicity, from the ethnicity framework, I was expecting a certain pathway with a socioeconomic one, and that wasn't the case. And yeah, so the fluidity of it is just adds to the complexity, I think, and the intersectionality is something that, of course, we all need to consider, really. The other point for me was the patient-practitioner communication and how that profoundly impacts on trial engagement. And although we talk about the external factors of trial engagement, the actual, sitting down and having that discussion with a practitioner, that conversation around a trial can be massively influential and can impact on whether that person says yes or no to go forward. So those factors that the public contributors put forward in terms of, things like trust, confidence, education, and the power dynamics of that conversation are really, really important. And again, something that that we need to look closely at. And then lastly, just the, again, and others have touched on this too, it's just the assumption that researchers already know the barriers to engagement. But we had, after the wider stakeholder meeting that we had, researchers were telling us things like, oh, well, I hadn't thought of that as an idea to address this, or I hadn't thought of that as an issue in terms of engaging people. So I think it's just around increasing understanding of patients' perspective will really help us to overcome many of the barriers. So even as a starting point, if we can identify and highlight those barriers, then we can then figure out how we can address them, really. So as I say, if we can identify them to researchers more broadly, then I think that will work towards then looking at how we can address them more proactively. Thank you.
Thanks very much. So just sharing what we've learned as well on top of those, and I would echo a lot of those points, but similarly, this issue and thinking about what capacity is and how it affects ability to give consent is even more complex than we first thought, and it's something I've been working on for quite a few years anyway. So the populations, the issues we've talked about, even the terminology is very different. So when we talk about cognitive impairment, cognitive disability, that seems to fit very well with some populations, but might not fit with the thinking of perhaps end-of-life care, for example, where we would perhaps think of it less as a cognitive impairment or a disability and more about a kind of stage of a kind of progression, really. But similarly, there's a huge amount of experience out there, and likewise, I've put research community, but I mean that in the broadest sense. So the research community, practitioner community, people living with impairing conditions and those that care for them have a lot of experience, and that they very much want to share that. So it's finding ways of kind of harnessing, collating and sharing that expertise that's out there, that's part of the challenge. But then importantly, this kind of whole toolbox approach is needed. So yes, the tools like the frameworks are very important, but alongside that, we need to provide researchers and the wider communities with the kind of knowledge around thinking about these kind of issues, training about how best to involve these kind of populations. And as you've already heard, resources including appropriate funding and appropriate funding for public involvement, because it's challenging to involve these populations in public involvement in the same way that we have to address the kind of challenges about involving these groups in research. But what people do want to focus on is solutions. We know what some of these problems are, and we need to kind of think about ways to address them rather than just reiterating and listing some of the challenges. We also know that completing the framework takes time. We heard that from the people that piloted with us, but it can help in multiple ways. So funding applications is how we often think about these kind of frameworks, trial design, but also particularly for the population I'm thinking about, the REC application, thinking about how that justification for including these groups in research can be explored when using the framework. And similarly to the others, I think evaluation is needed to find out if it's helpful, for whom, how and why. And then alongside that, we need to think about tools to help support implementation as well. So thinking about the slides, perhaps videos, perhaps workshop materials that might help use the framework in practice. And I'm going to hand over to Heidi, who's going to talk about what next.
Yeah, so I'm just going to go through some very quick projects that we're all currently working on. These are linked to the ethnicity framework primarily, mainly because that is more established, because it's being used. and therefore we've had time and breathing space to think of what we need to do next. So the first one is Merit, so Minority Experiences in Trials, and that is a funding pot from the TMRP that I got some money from last year. And we are conducting a rapid qualitative evidence synthesis. Should have thought about that before doing the project. I just didn't want to say that. So we're doing that qualitative evidence synthesis, and we are going to be mapping evidence to find solutions. So that is all focused on ethnic minorities in trials and how they engage with trials, and how we can then map that onto the strategies that may have come out of the Cochrane Review, for example, to see where the gaps are. The next thing, which links in heavily with Merit, is Stride. So that's a new project that we started last month. Now it's February, funded by CSO. Sean's the PI, I'm the research fellow. We're all doing the same thing. So this is supporting recruitment and retention improvements for diverse ethnicities. And essentially this will be providing more tools from the ethnicity framework. So we'll be completing what feels like 1 million more example ethnicity frameworks. I think there'll be about 23 additional ones on the website, and we'll be doing small sort of guideline panel-esque type things to figure out what the percentage and the proportion of people, and that will be broad. So it's not going to be like you need 4% of this. It's going to be a broad estimation of the types of people that you need in trials based on the intervention type and the disease area. So it could be that we go in and say we need more South Asian populations to engage with diabetes trials, for example. And that'll include lots of different types of trials in there too. And then Included, which is led by Sandra Eldridge at QMUL, with also Ratna Sahanpal and Sean Newton and myself. And that's really focusing on the way that we collect ethnicity data. So we knew from the ethnicity framework development that collecting data was a really big part of that potential issue that could come up. So if people don't see themselves in the categorizations that are presented to them, you know, if you see Asian and you don't think of yourself quite as Asian, maybe you want to be Chinese or Japanese, you know, you want to be more, you don't want to be put in a box that doesn't quite fit you, essentially. So what we're doing as part of that work is to do focus groups and interviews with those communities. So in a hilarious twist of events, we all thought we'd be doing the interviews, and then by the end of it, we're like, okay, we need these communities to do them. So we'll be training up new researchers to be doing these focus groups in different languages too. So that's all a learning curve for us. And then the four of us, Sean, Vicky, Fran, and I, are advertising for a PhD project through the TMRP that will pull all of our frameworks together, as Fran had mentioned earlier on, I think, with intersectionality in mind. So this is, again, trying to stop duplication of effort, stop too much work being done, so that we can put all those frameworks together and hand essentially a little bundle, streamlined bundle to trial teams to then be able to complete that before they go in with their grant applications. And the deadline for that is February 18th. So you still have time to apply if you wish. And that's it. I think that's the last slide.
It is. That's it, Simone. So thank you to everybody for your attention. And if there are questions, I guess we'd be happy to try and answer them. I'll stop sharing.